Bismillah Rahman Rahim. Today we will discuss about the giant tumors and tumor-like conditions. In this, we have two groups, benign and malignant. In the benign, there is ganglion, which is also called synovial cyst, and giant cell tumor of tendon sheath, also called pigmented villonodular synovitis, tenosynovitis. And malignant one is synovial sarcoma. So these are the giant tumors of the giant. So what is a ganglion? So ganglion or synovial cyst is a small cyst that is about 1 to 1.5 centimeter. And this results from mixed degeneration of fibrous tissue, connective tissue. And it is often located near a giant capsule or tendon sheath. And most common location is the wrist joint. There is herniation of synovium through the giant capsule or massive enlargement of a bursae that produces a synovial cyst. And synovial lining may be hyperplastic and contain inflammatory cells and fibrin. So that is ganglion. Other benign tumor is giant cell tumor of tendon sheath or pigmented villonodular synovitis. So this is of two types. One is diffuse type and other is localized type. And it develops in the synovial lining of giants, tendon sheaths and bursae. Age of patients is 20 to 40 years. And there is translocation of the chromosome between 1 and 2. And tumor cells overexpress colony-stimulating factor 1, a chemoattractant for macrophages which infiltrate the tumor in large numbers. Giants affected knee, joint, hip, and ankle. Variants are types of giant cell tumor of tendon sheath. So one is diffuse type, that is pigmented villonodular synovitis. Other is localized type, giant cell tumor of tendon sheath. The affected giant becomes painful and there is reduced movements and there is recurrent swelling. Grossly, they are red-brown in color. In diffuse type, red-brown folds and finger-like projections and nodules may be found. And the localized form is well circumscribed. Under the microscope, we see neoplastic cells which are polyhedral, moderate-sized, and resemble synoviocytes. They spread along the surface and infiltrate the subsynovial tissue. In a solid aggregate, they may be attached to the synovium by a pedicle. There is infiltration by macrophages, which may contain hemosiderin and lipid-filled vacuoles, and they may form multinucleated giant cells. That is why it is called giant cell tumor of tendon sheath. So this is the gross appearance, multiple papillary projections due to hyperplastic synovium and infiltration by macrophages. So this is hyperplastic synovial cells, polyhedral type synovial cells, and there may be multinucleated giant cells containing multiple nuclei. So that is about the benign tumors. Then synovial sarcoma, it will be discussed in soft tissue tumors. So soft tissue tumors may rise from fat, fibrous tissue, or fibrohistiocytic region, the skeletal muscle fibers, smooth muscle fibers, or vessels, or peripheral nerve, or in certain tumors there is uncertainty about the cell of origin, like synovial sarcoma, alveolar soft part sarcoma, epithelioid sarcoma, or clear cell sarcoma. So synovial sarcoma, alveolar soft part sarcoma, epithelioid sarcoma, their origin is uncertain. Causes of soft tissue tumors, mostly they are unknown. Some are associated with radiation and chemical burns or thermal burns. Trauma sometimes may be predisposition to development of sarcoma. Some viruses like HHV8, human herpes virus 8 for Kaposi sarcoma. Then there are different genetics which are important, and sometimes sarcomas are parts of many syndromes. And there are many chromosomal translocations. As we will see, most of the sarcomas, they are associated with different chromosomal translocations. So this is the table showing different chromosomal and genetic abnormalities in the soft tissue sarcomas. So first is extraosseous Ewing sarcoma and primitive neuroectodermal tumor. So there is translocation between chromosomes 11 and 22. Q24, Q12. And genetic abnormality is the resulting fusion gene, FLI1EWS. Similarly, liposarcoma, mixed and round cell variants, translocation between chromosome 12 and 16 at Q13 and P11. TLS fusion gene, CHOP. And synovial sarcoma, similarly translocation between chromosome X and 18, P11 and Q11. The fusion gene is synovial SYTSSX fusion gene. Similarly, there are different translocations in different types of soft tissue sarcomas. So all soft tissue sarcomas, they are composed of spindle-shaped cells, and some may be superficial in location, or sometimes they may be deep. And the prognosis of soft tissue sarcomas depends on the staging, and then staging depends on number of mitosis, polymorphism of the component cells, and then necrosis, areas of necrosis. And then there is importance of immunoperoxidase staining, and importance of consultation with surgeons and other consultants. So first, we will discuss about the tumors of fat, that is benign. One is lipoma, and malignant tumor of fat cells is liposarcoma. So this picture is normal fat. So you see few fat cells with clear cytoplasm and peripherally located benign nuclei. And in lipoma, there is a capsule on the outer side, and these are the multiple fat cells with clear cytoplasm. And this is lipoma. And this is liposarcoma. There are fat cells as well as atypical spindle-shaped cells. So we will discuss these in some details. So lipomas, they are often seen in adulthood, and the sites commonly affected, they are proximal extremities and trunk. Then there are various types of lipomas. One is conventional lipoma, fibrolipoma, angiolipoma, spindle cell lipoma, myelolipoma, and pleomorphic lipoma. So depending on the components of the lipoma, if there is fibrous tissue and fat cells, fibrolipoma; if blood vessels and fat cells, the angiolipoma; if the component cells are some spindle-shaped spindle cell lipoma; if there is bone marrow, myelo means bone marrow, then myelolipoma and pleomorphic lipoma. So chromosomal rearrangements of 12, 13, and 16q. They are well encapsulated. Benign tumors, they are often well encapsulated. So then is liposarcoma. So malignant tumor of fat cells. So most of the patients, they are between 40 and 60 years. And deep soft tissues of proximal extremities, retroperitoneum, they are the common sites. And then is the types of liposarcoma. One is well differentiated, another is mixed or round cell tumor, and pleomorphic variants. So for diagnosis of liposarcoma, there must be primitive cells, fetal fat cell, that is lipoblast. So this is mixed liposarcoma. There are areas of mixed background, then spindled to ovoid cells with lipoblasts like this. Then is fibrous tissue. So benign tumor is nodular fasciitis and FIBROMATOSES, and the malignant one is fibrosarcoma. So reactive pseudosarcomatous proliferations, they are non-neoplastic lesions, and they often develop in response to some form of local trauma, physical or ischemic, or they may be idiopathic. And these reactive proliferations of fibrous tissue, they are composed of reactive fibroblasts and related mesenchymal cells. And due to hypercellularity and mitotic activity and primitive appearance, they may resemble a sarcoma. And among this, there is nodular fasciitis and myositis ossificans. So what is nodular fasciitis? It's a benign condition of excessive proliferation of fibroblasts, which may resemble sarcoma. Most of the patients, they are adults, and forearm, chest, and back, they are the common sites. And there is several weeks history of a solitary, rapidly growing, painful mass. So history is important. The nodular fasciitis patients, they often complain of a rapid developing or growing mass formation, which is painful. And the nodular fasciitis is situated in the deep dermis or subcutis, or sometimes in the muscle, and they are maybe many centimeters in diameter. They are nodular and poorly defined margins. Under the microscope, they are very cellular, and there is a collection of plump, immature appearing fibroblasts and myofibroblasts. They may be arranged randomly or in short fascicles. And there are many mitoses, and stroma is frequently mixed-site and contains lymphocytes and extravasated red blood cells. And often they are recurrent after excision. They may recur after excision. So this is the microscopic appearance. There are spindle-shaped fibroblasts and myofibroblasts, and these are extravasated red blood cells. So they are the microscopic appearances of nodular fasciitis. Plump fibroblasts. Then is myositis ossificans. There is benign fibrous tissue and proliferation of the fibrous tissue. There is plus osseous metaplasia. So this is the X-ray of myositis ossificans, and this is the gross appearance and microscope. So, young adults, they often follow trauma, and muscle of proximal extremities, they are involved. In early phase, there is swollen and painful mass formation, which is hard and well demarcated. Fibroblasts and myofibroblast-like cells, they are surrounded by an intermediate zone that contains osteoblasts and trabeculae of woven bone. So, myositis ossificans. The most peripheral zone contains well-formed mineralized trabeculae that resembles cancellous bone. So this is the bone, normal bone, and this is myositis ossificans in the surrounding muscle. There is trabeculae, bony trabeculae formation. Then is FIBROMATOSES. It may be superficial, that is present in the palms or sole of the foot, genital organs, fibromatosis. It may be nodular or it may be poorly defined, and it is composed of broad fascicles of fibroblasts and myofibroblasts surrounded by abundant dense collagen, and sometimes they may also recur. And then is deep-seated fibromatosis, which is also called desmoid tumors. Teenagers to 30 years age group, they are often large and infiltrative masses. They also recur after incomplete excision. They may be abdominal, intra-abdominal or extra-abdominal, and mutations in APC or beta-catenin genes may be seen. There are plump fibroblasts arranged in broad fascicles that infiltrate the adjacent tissue. Deep fibromatosis are desmoid tumors. So you can see this. These are the fibroblasts and myofibroblast-like cells which infiltrate the surrounding muscle cells. These are the skeletal muscle cells. Fibromatosis are desmoid tumors. So they are benign. The malignant tumor of fibrous tissue is called FIBROSARCOMA, and they are situated in deep, soft tissues of the extremities. They are often non-encapsulated and infiltrative soft masses, and they show all degrees of differentiation. And the arrangement of these cells in fibrosarcoma herringbone fashion, and sometimes they may show architectural disarray, pleomorphism, frequent mitosis, and areas of necrosis. They often recur and metastasize to distant sites. So this is the microscopic appearance of fibrosarcoma. Spindle-shaped cells, fascicles of spindle-shaped cells arranged in herringbone pattern. This is the herringbone pattern, like this. So this is another view of like a fibrosarcoma, multiple pleomorphic cells, quite undifferentiated fibrosarcoma. So then is FIBROHISTIOCYTIC tumors, benign fibrous histiocytoma, and then dermatofibrosarcoma protuberans, and then malignant fibrous histiocytoma. So benign one is this fibrous histiocytoma, and dermatofibrosarcoma protuberans is a borderline malignant. MFH, that is malignant fibrous histiocytoma, is a highly malignant tumor. So that is about the fibrohistiocytic tumors. In next lecture, we will discuss other soft tissue sarcomas.